This is cardiac monitoring and treatments. It's oxygenation 2A. It's part of your oxygenation and heart lecture. So we just review the conduction of the heart. So you have your pacemaker of the heart, which is your SA node. Your pacemaker kick-starts the heart, right? Sits in the upper atrium. That signal spreads over the atrial myocardium. The impulse travels to the AV node, right here. And then it travels down through the bundle of His and into the Purkinje fibers. So your SA node fires usually 60 to 100, hence the heart, your normal heart rate. Then your AV node fires 40 to 60. Your SA node to your AV node kind of bridges the signal from the atrial to the ventricle. And then it goes down to your bundle of His and your Purkinje fibers. That just says His, bundle of His, HIS, and Purkinje system. And those fire at about 20 to 40. Those are all good to know things. Definitely have an understanding of the way things work, just so you can understand dysrhythmias. So as far as these little purple dots that I've marked here, those are just backup pacemakers. You will see these accessory pathways, and this ectopic focus sometimes with AFib. When we talk about AFib, we'll talk about how these little ectopics are trying to get to fire. So they're like little secondary pacemakers. All right, so our cells are what make all this happen. So we've got automaticity, the ability to initiate an impulse spontaneously. Excitability, the ability to be electrically stimulated. Conductivity, the ability to transmit an impulse along a membrane. And contractility, the ability to respond mechanically to an impulse. So our SA node fires with automaticity, right? Spontaneously. Conductivity, that's the little pathway I just showed you where it goes from SA node to AV node, conductivity. And then contractility is the heart squeezing, right? So all of this is made possible with specialized cardiac cells. That whole action potential and all those cells doing all that. ATP. All right, so then there's the nervous system control of the heart, right? Parasympathetic, sympathetic. So your sympathetic nervous system innervates the heart and the blood vessels. It increases impulse control of the AV node, increases the SA node, and increases cardiac contractility. All this is part of your sympathetic nervous system. Remember, sympathetic nervous systems go, parasympathetics put on the brakes. Sympathetic nervous system is fight or flight, parasympathetic is rest and digest, right? So, often you'll refer, both of these, you'll hear people refer to it as the autonomic nervous system, right? They're talking about both of these, SNS and the parasympathetic. So when you hear somebody say they vagal down, what happened? Well, stimulation of the vagus nerve causes a decreased rate of firing for the SA node and a slowed impulse in the AV. So that's why when someone vagals, their heart rate drops. Because it's a decreased, the pacemaker of the heart's not doing the kick that it needs to. So then your parasympathetic is mediated by the vagus nerve. It'll slow AV conduction and decrease the rate of the SA node. And it slightly decreases cardiac contractility, but not significant. But it can help with it. So, dysrhythmias are basically a disorder of the impulse formation. Remember I said it's a disorder. It's not going the way it should go. That normal pathway, SA node, AV node, bundle of His, Purkinje fibers, there's a disorder. There's a disorder of conduction impulses or both. So there's a disorder of impulse formation. Remember I said that those little, those foci, those ectopics over here, that could be a disorder of the impulse formation if they decide to fire, right? There's some excitability there. Or disorder of the conduction, or both. So that is your basically a definition of dysrhythmia. And then what is your electrocardiogram monitoring? Well, it's basically graphic tracing of electrical impulses. The waveforms represent electrical activity produced by movement of the ions across the membranes of the myocardial cells. So you've got your action potential, right? Constant movement to depolarize and repolarize these cells. Did I leave calcium's there too? I mean, calcium does do some stuff, but your potassium and sodium do a lot, right? And this is a review. Should be a review for probably anatomy. Way back. But this is really, I mean, this is a good to know, but this is important to know so that you can kind of understand depolarization and repolarization, right? Because there's got to be this constant moving of this action potential and all these cells for these impulses to create the waveforms on our graph, right? So basically graphic tracing to create waveforms. You got a constant depolarization and repolarization due to the action potential. All right, so let's look at it a little closer. We've got our P, our QRS, and our T. And then I highlighted that isoelectric line. That's your isoelectric line is your line where everything should come to, kind of your baseline. And then your P wave is your time through the atrium, or atria. Your QRS is your depolarization of the ventricles. And then your T is your ventricle repolarization. PQ. Yep. Your P is your AV node is your PR interval.
What's number 2 on the top left? It's time 3 tram, but what's the actual?
That's your P.
PR. Alright.
Yeah, PR, because it goes all the way here. Well, this is PQ, but your PR would go to your R here.
Because number 2 is PQ.
Yeah. Alright, so I just got another visual for you. You got your atrial depolarization, your ventricle depolarization, and then your ventricle repolarization. And remember they said, remember that the atrial repolarization is kind of lost in that QRS. So your P wave is your SA node, right? It kick starts. It goes down into the AV, right? Conducts down into, okay, so that's your P. Your PR is your AV conducts. QRS is your ventricles conduct. So P, got a little P wave. And then number 2, you got your P to R, which is your AV node. And then your ventricle goes down into the bundle of His and the Purkinje fibers, and you get your QRS. Or your spike there. It shows you the different leads. So sometimes the waves look different in different leads. You're like, does it look upside down? No, it's just taking it from a different angle, right? So I wouldn't spend a lot of time trying to memorize V6s where, you know, just be aware that sometimes if you see a rhythm that looks upside down, it could just be the lead that it's in, okay? The lead that's capturing it. As far as time, you want to look at each small square. So you see how that's a strip. And then it's got the big square, and then it's like it's magnified into the smaller square, okay? So each small square is 0.04 seconds, or 1 millimeter wide. And then each large square is 0.20 seconds, or 5 millimeters wide. You have your 3-second markers here. That's often a way to tell if you've got a 6-second strip. Alright, so I just highlighted your 3-second markers and then 6-second strip. I just wrote on there 6-second strip. Alright, so let's calculate the heart rate. What is the heart rate when we talk about rule of 300? It's in your book. Rule of 300 is basically your heart rate equals the 300 over the number of big squares between two complexes. Now this is a way to calculate heart rate if you have a regular rhythm. If it's irregular, it's not so accurate. So this is for regular rhythms. So we're going to do this. So I counted 1, 2, 3, 4, 5, 6 big boxes. So I divided 300 divided by 6 equals 50. And that would be your estimation for a regular heart rate using the rule of 300. Now you can also use the rule of 1500, and your book has that as well, I believe. And that is, you just count the smaller boxes, those tiny little ones, remember? If you don't want to count them, do some math. 1500 divided by 30. So remember, if you go back, there's each large square is 0.20 and each small square is 0.004. So there's 5, right? If you think 5. So 6 times 5 is 30. 1500 divided by 30 equals 50. So 5 small and 1 big box. You got 5 small squares and 1 big box. And that's the rule of 1500. And that's the way to calculate. You can calculate if you have a regular rhythm. You can also, well, I'll give you all a minute to write. And then you've got assessment of the cardiac rhythm by just counting the complexes. And again, this is for a regular rhythm, but you see, you can just count 1, 2, 3. You count spike to peak to peak, right? 5, 6, 7. Heart rate would be 70. This is something you can do on a 6-second strip.
That one has to be on a 6-second strip.
Yeah. This one would have to be on a 6-second strip to count intervals. You're just counting the complexes. And then, of course, you got artifact, right, on an EKG sometimes, or on a monitor. If you're taking care of a patient that's wearing a monitor. That can be, you always want to check the equipment. I tell a story of how my patient was brushing her teeth. It looked just like she had AFib. And went to check on her. She was brushing her teeth. So always make sure you check the patient. You never treat the monitor, right? You always check the patient. Check the equipment. Is the battery dead? Is there a lead wire off? Is the skin oily and the patches are not sticking down? Do they need their hair clipped? Like a trim. They've got too much hair and the pads are not sticking, so you're not getting a good reading. So there could be several things that's going on. You'll get a call from central monitoring. They'll say, this patient, I think there's artifact. It could be VTAC. You need to go check them. So just be aware of artifact and be aware that we treat the patient, not the monitor. And, you know, they have advanced alarm systems now to detect dysrhythmias, too. So that's why we always want to answer our phone and make sure if it's telemetry calling that we check on our patient. As far as assessment of the cardiac rhythm, you want to interpret the rhythm. So we're looking at a rhythm. We want to interpret the rhythm. What is this? Is it sinus tach? Is it sinus brady? Sinus supraventricular tachycardia? And then you want to evaluate the clinical status. How is the patient? Are they symptomatic? Are they asymptomatic? Okay, so you always evaluate the patient, the clinical status of the patient. And are they hemodynamically stable? So how can you tell if your patient's hemodynamically stable without invasive monitoring? Blood pressure and heart rate, right? And how they're acting, LOC, are they dizzy, that kind of thing. So whenever you see a heart rate, like a fast heart rate, say sinus tachycardia, what are you going to do? You're going to determine the cause. Why do they have sinus tachycardia? Do they have fever? Are they in pain? So determine the cause. Someone that has SVT, Why is their heart going 180? So you want to determine the cause. What's causing it? Because a lot of what we do, we don't actually treat the underlying cause, but we take care of the underlying cause, right? So we're looking all the time for the underlying cause of the problems. What is the treatment for this rhythm? So these are the things you need to think about when you're looking at a cardiac rhythm. You want to check the isoelectric line. And we'll talk about that when we talk about ST elevation. But does the wave come back down to the isoelectric line, or is it above the isoelectric line? Is there a P wave? So these are some things you're looking at. And is the QRS wide or is it skinny? If it's wide, that's not usually a good thing. Why do you think that is? If it's wide, what do you think the ventricles are doing? They're working overtime, right? Or they're not working very well. So if it's wide, that's not good. So remember, treat the patient, not the monitor. All right, so we're going to get right into the rhythms. We want to talk first about normal sinus rhythm. Your sinus node fires, rate 60 to 100, right? Rhythm is regular. Your P wave is uniform and upright. And you have a P that precedes a QRS. So your nice, perfect little rhythm there, right? Normal sinus rhythm. It follows the normal conduction. All right, so let's talk about bradycardia. Usually that's a rate of less than 60. The rhythm is regular again. Your P waves are uniform and upright. Your PR interval is 0.12 to 0.20. I wouldn't spend a lot of time. You don't have to memorize that. But definitely know less than 60, right? And let's talk about the significance of it. Because these are things you do need to know. So what exactly is it? It depends on how the patient tolerates it. Are they symptomatic or asymptomatic is how we're going to treat it and how their clinical manifestations are. So a lot of times you got athletes, someone that has a vagal response, they may be Brady, they may Brady down. Athletes, that's normal for them to have a slow heart rate, right? And then sometimes you may see bradycardia if someone's has some different disease states, such as like sick sinus syndrome, or sometimes with coronary artery disease. So sometimes you will see some sinus bradycardia for different reasons. And then as far as what you're going to see hypotension. They may be pale, cool, skin, pale, cool skin. I don't know why I put a comma there. Weakness, chest pain, dizziness. They could be disoriented. They could even have shortness of breath. I mean, because you got to think, if they're not an athlete and their heart is 40, they are not perfusing their tissues, right? So you're going to see some side effects. So as far as treatment, that depends on the cause and how the patient tolerates it. Okay? So symptomatic, which would mean what? Showing signs. They're dizzy, they're hypotensive, they're pale. So symptomatic, if they are symptomatic, we are going to give them atropine. They may discontinue the drug that's causing the bradycardia. For example, your patient that's on a beta blocker, their heart rate is 50, and they're dizzy every time they move, and they're weak. Well, we've got those wonderful parameters, right, that say hold it if it's less than 60. So they may hold or discontinue the drug if it's frequently causing someone's heart to be low and they're symptomatic. They're complaining about it, or they're showing symptoms clinically. So symptomatic treatment, atropine, discontinue the drug, or a pacemaker, or a transcutaneous pacemaker. Now, transcutaneous pacemaker is more kind of an emergent thing. That would be someone that's extremely hypotensive, that they're symptomatic, and they're in the ER, and they decide to, they'd rather give them a pacemaker as opposed to atropine, or whatever reason the doctor decides to do a pacemaker. A transcutaneous just means that it sits on the skin and gives them little shocks. We're going to talk more about that when we talk about pacemakers. But then the regular pacemaker, you know, they have a little surgery and they insert a pacemaker inside them under the subcutaneous tissue. But a transcutaneous often will be done for symptomatic bradycardia as well. So sinus tachycardia, you've got a rate of 101 to 200. Your rhythm is regular. P waves are uniform. You got a normal shape and duration of your QRS. See how nice and thin it is? It's a skinny QRS. It's not wide. It's a normal shape and duration.
It's fast.
It's fast. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 15, 150. So typically, it says 101 to 200. It can be considered sinus tach. Typically, we're going to talk about sinus SVT, and usually, if you see it somewhere, then SVT is usually like greater than 150. So just keep that in mind. We're going to talk about SVT. But your book has, I think, sinus tachycardia as it could be up to 200, so 101 to 200. But typically, you'll see it get up to 150, and then above that, it's kind of hard to read, so they might call it SVT. So what is it? It depends on the patient's tolerance of the heart rate, right? Sometimes drugs can cause it. Sometimes legal, sometimes illegal. Stress can cause an increased heart rate. Remember I said you constantly under stress, you got a constant fight or flight, sympathetic nervous system's in overdrive. Well, you're going to have an increased heart rate. Sometimes if someone has a vagal inhibition, like for whatever reason their vagal nerve's not working. Because remember, the vagal nerve is the one that actually is the parasympathetic. The rest, digest, breaks. So, as far as manifestations, what are you going to see? Well, they may be dizzy. They may have shortness of breath. They may have low blood pressure. They may have chest pain. They could have a fever. That could be causing it. That's where we're at. We're at the treat now. So as far as the treatment, we want to treat the underlying cause. Yes? Pain. Yep, pain can cause tachycardia. So you want to treat the underlying cause. So if they're in pain, you want to give them some pain reliever. If they have a fever, you want to give them some Tylenol or bring down the fever if they're clinically stable. We might do some other things, but treat the underlying cause first. Okay? So you want to treat your underlying cause first, and then if they're stable and they really can't figure out why they have an increased heart rate, they may give a beta blocker or they may do some vagal maneuvers. And if they're extremely unstable, they could even do cardioversion, but don't even worry about trying to remember that.
So the main thing for this is just treat underlying cause.
Treat underlying cause is something to remember. All right, and then first degree block, that's just your normal 60 to 100. Rhythm is regular. You have a P wave that precedes a QRS, but your PR interval is greater than 0.20. Remember I said the big box is 0.20? Well, your P wave is going to take up a whole big box, maybe a little bit over. So greater than 0.20. See, I underlined it there for you. See how it takes up a big box, greater than a big box? That's a tongue twister. Greater than a big box. So as far as significance, it can be associated with an MI, rheumatic fever, hypothyroid, electrolyte. I wouldn't try to memorize all that. Just know that there are some problems that can cause this. But as far as the treatment, well, let's talk about manifestations. Usually you can't tell. They're not going to have many. They're asymptomatic. Usually. So usually the way you find this is they're on the heart monitor and telemetry calls, or you see it, either one. But as far as treatment, there's really no treatment. You're going to monitor this patient for changes. Because if they have an MI, it could change, right? If they have hypothyroid or an electrolyte imbalance, it could change. So with these patients, you're just monitoring them, looking for changes. All right, so let's talk about PSVT. You may hear this referred to as SVT, supraventricular tachycardia. You may hear it called paroxysmal. Paroxysmal just means sudden onset. It just means it happened quick. So you got a rate to 150 to 220. Your rhythm's regular, sometimes slightly irregular. This one you can tell looks a little irregular. And your P wave is hidden in your T wave on this one. Sometimes you can see, sometimes you can think you see the P wave, but it's the T wave because it's going so fast. And your QRS is usually nice and skinny and normal. Okay? A lot of people get confused with this because it's supraventricular, but you want to think supra means above the ventricles. So this rhythm is above the ventricles. It's just a disoriented rhythm above the ventricles. It's back to the abnormal conduction. So it's re-excitation, so the atria is getting excited, or you're getting another ectopic beat in there. So you're getting extra beats, right? Significance depends on the associated symptoms. How is the patient feeling? Oh, I just drew that's my little heart there. Looks like a butterfly. And I just drew that line to let you know it's above the ventricles and to help me remember to tell you that. As far as manifestations, they may have low blood pressure, because think, okay, if my heart's going 180, then it's not completely filling properly, right? And if it's not filling properly, then I'm going to have decreased cardiac output, decreased blood pressure. Does that make sense? Might have shortness of breath. Might have chest pain. Again, anytime it's going so fast that it can't go through the proper cycle and the filling and all, then you could get chest pain too and decreased cardiac output. So decreased cardiac output, decreased stroke volume, usually with a heart rate greater than 180. That's when you're going to see that, because it just can't keep up the cycle. The atrial's going so fast, and the ventricles just sending all that through, and the ventricles can't keep up. So often the treatment is vagal stimulation. So they're going to tell them to bear down. I've seen doctors have somebody they couldn't get their heart rate down, put their head in ice water, blow through a straw. So they'll have them get a skinny straw, not a big straw, but like a skinny straw. Yeah, like a coffee straw, and blow through it, and that will bring down your blood pressure. So there's different ways to kind of vagally stimulate. And then IV adenosine or adenocard but adenosine is your treatment for SVT. Put your star by that, okay? Adenosine, IV adenosine. That stops the heart and restarts it. Mm-hmm. Yeah, for a second. Beta blockers, so all of these things. So because I was pretty much asymptomatic, I felt like my heart was still flip-flopping in my chest, but my blood pressure was fine. The doctor just started me on a really, really, really low dose of atenolol, like half of the normal dose. So he ordered like the 12.5 tablets, and I cut those in half because my blood pressure runs naturally low, so he didn't want to bottom me out. He just wanted to try to bring down my my heart rate.
This one, what is the most important?
Okay, so there are some other drugs, amiodarone. They can't even do cardioversion for these patients. I helped take care of a patient. We tried amiodarone on him. I don't know why the doctor didn't do adenosine, but he did amiodarone, and then he actually cardioverted him. So depending on how serious they were, he was basically very unstable. I was like, he needs to go to ICU. But we started an amiodarone drip, and then he cardioverted him, and it helped. The cardioversion helped. But I wouldn't try it. I just remember the IV adenosine, but it is listed as a treatment. And then potassium channel blockers. Again, I wrote your 771 are your anti-dysrhythmic drugs. It's got your amiodarone, all of these listed. Your adenosines listed on this 771 as well. All right, AFib. Atrial fibrillation is exactly what it says. It's fibrillating. The atria are just kind of quivering, right? Fibrillatory waves. The rhythm's irregular. Your atrial rate is going at like 350 to 600. Your P waves are chaotic, erratic, fibrillatory, like I said, and your PR interval is none because it's going so fast you can't really see it, and your QRS is normal. So you can see all the little squigglies in between your QRSs. It's irregular. You notice how it looks irregular between the QRSs? Yeah. So you have an irregular rhythm. It's total disorganization. Okay, and then P wave is erratic, wavy, irregular. It's the most common dysrhythmia prevalence with increased age. So, the elderly, so you see a lot of elderly with this. But I've seen young people with it too, but a lot of elderly. It occurs with underlying heart disease usually. Sometimes after a heart attack, they're more prone to this as well. Heart failure, they're more prone to this. And then electrolyte disturbances, stress. If they're in AFib greater than 48 hours, they're going to put them on an anticoagulant. Why do you think that is? Right, those clots just kind of stasis. They get stasis clots there in the atrium, and they could have a stroke. So they're going to put them on an anticoagulant. You're going to see decreased cardiac output again because the heart's can't keep up. It's not filling and emptying properly. Decreased blood pressure, dizziness, the increased heart rate, and irregular heart rate. So as far as drugs go, or treatment, drugs to control the ventricular rate, or to convert them to normal sinus rhythm, like amiodarone, calcium channel blockers. I've seen them give cardiazem, so they'll try drugs often. Beta blockers, digoxin, they'll try drugs, but they also will cardiovert them. That'll help reset their rhythm. So I put a little star by cardioversion because it's often used for this. We're going to talk more about it.
Won't they also do an ablation on chronic?
They can. They do this procedure called a Maze procedure, which is like an ablation. That is a treatment for it. Can be. If they do cardioversion, they want the patient to be on anticoagulants for 3 weeks. Because what are you doing? You're shocking the heart, right? With a lower dose, you're still shocking the heart. You could dislodge a clot. Okay? So they want them to be on anticoagulants. Coumadin, because of the quivering of the atria. So what is the therapeutic range for Coumadin?
Coumadin? 2 to 3.
2 to 3. Yep. Coumadin INR is 2 to 3. So that would be important to know. And then just make sure that they're on anticoagulants for 3 weeks. And this is cardioversion. So you're going to use a defibrillator, right? You're going to use, just like you would shock the heart when they stop beating, you're going to use a defibrillator, but it's going to be in synchronization. You see this lady, her finger is on charge, but the synchronization button has to be mashed to do cardioversion. You're cardioverting them, their rhythm, basically. You're not defibrillating, stopping the heart, trying to restart the heart. You're cardioverting the heart. So you want the sync button on. That's why it's called synchronized cardioversion. This is a nice picture. It shows you that they're in AFib. It shows the shock. And then it shows they go into a normal heart rhythm. They usually do it on low dose, 50 to 100. I have seen them do a little bit more on a bigger person, but usually 50 to 100. It has to be timed, and you want to shock. They shock on the R wave. But it can be emergent or elective. So you want to make sure you have informed consent. So we would always make sure when they came in, if we didn't have time to do the admission history, we made sure we got an informed consent if they were able to sign. And we also made sure they've been on anticoagulants. And if they weren't, they'd do a TEE, but you don't need to know that. We give usually Versed or Propofol. Versed, that it is painful. They will come up off the bed, but they won't remember it. They usually just go, ugh, or they make a, ow.
What do you mean you do transesophageal TE?
TE. So you want to remember this slide. Make sure you know this slide. You want your sync button on. And I just made a line there to show you the cardioversion. This is another picture it shows you a bigger wave when it cardioverted, but it, again, AFib, shock, normal sinus rhythm. They're using the paddles here. Most of the time now we use just the pads. I have seen the doctor put paddles on a bigger patient just so they'll get some good conduction, but just to kind of hold pressure and help with it. But all right, so now we're going to go into a flutter. We're almost done, guys. A flutter, atrial rate is 200 to 350. Your ventricular rate is 150. I wouldn't try to memorize these on this, okay? On these AFib and A flutter, these rates. But know that they're fast and try to remember to recognize what it looks like. So this one, even though it looks kind of like AFib, you got this sawtooth pattern usually. It's what kind of helps you recognize flutter. It's more of a sawtooth. It's a little sharper. It's not as squiggly and fibrillatory. It's sharper. So just kind of remember sawtooth. It's usually regular. So your fib is irregular and your flutter is usually regular. It can be irregular, but usually regular. Your P wave is like a sawtooth, so it's sharp. Your interval, you really can't, you just can't measure it, right? There's really no interval. Did you get it? Typically, it's associated with CAD, hypertension, COPD. Just basically, there's an abnormal circuit inside that right atrium. So you're just kind of getting a abnormality, a circuit of conduction. It's not going through the normal conduction. So you got a loss of your atrial kick, and they have an increased risk of stroke too. Decreased cardiac output, decreased blood pressure. Again, because it's going so fast, right? They have an increased risk of stroke too. They need to take warfarin or Coumadin. Often they'll be treated with calcium channel blockers. Beta blockers sometimes can be used. They can do cardioversion and anti-dysrhythmics, just like even like I've seen people take amiodarone for it. So anti-dysrhythmics, cardioversion. Often, though, especially for younger people, because I have seen some younger people, they'll do ablation. Because younger people, they don't want to take a bunch of medicines, a bunch of anti-dysrhythmics and blood thinners. So they'll at least try like the little procedure called ablation. So the ablation is a treatment of choice for most because they don't want to take a bunch of medicine.
Treatment of choice across the board.
Again, it depends, you know.
We had a start.
I got to start by it, so I'd remember that. A flutter ablation, AFib cardioversion. I remember that. But of course, they're always going to try meds first, right? That's typical. Unless they're unstable, and then they might do something different. But this is a procedure. Ablation is a procedure. So they got to be pretty stable to take them up to the cath lab and do this, to the EP lab. So, of course, they're going to try medicines. And it's usually like, okay, I'm tired of taking all these medicines. I want to try something else, so they'll try the ablation. What is ablation? It's just an electro-tipped ablation catheter. They look for the pathway, these sites that's causing these irregular pathways, and they will laser them. They put it's just like the same kind of procedure. They go in through the groin and they go up and they look for these pathways. I've seen these procedures take hours because they're trying to find these pathways. So care is similar to cardiac cath. These patients usually would stay overnight with us, and we'd monitor them, monitor their, just like a cardiac cath site, you know, their bleeding and things like that. I think that is all. I just got a little visual here for you between, so you can understand AFib, A flutter. So your A flutter is, you see the, you've got a short circuit, right? So it's just going round and round and round and round and round instead of doing what it's supposed to do. And then your fibrillation is, you got all these little ectopics trying to start a rhythm or kickstart the heart, and so you just got a bunch of fibrillatory waves. I have a little visual for you that I drew. So you got normal conduction. That's your normal conduction. Your SA node to AV node down to your bundle of His and your Purkinje fibers. Whereas here, it's not normal. It's just going round and round and round. It's just like a short circuit. And then here you've got all these little ectopics. So sawtooth is your A flutter, short circuit, your AFib, many ectopics or many signals. The heart's getting many signals, and an irregular beat.